My name is Gabrielle. I am a research fellow at Boston Children's Hospital, also affiliated to the Broad Institute in Boston. Thank you very much for inviting me to this meeting and for the opportunity to participate in today's meeting. And today I'll talk about, actually I'll do an overview of KAT6B disorder. So I started to work on KAT6B in 2018 during my residency training at St. Justine Hospital in Montreal. That's where I worked on the delineation of the genotype and phenotype of KAT6B disorders and its clinical management with Dr. Philippe Campeau, who's based in Montreal and has been working on this gene kind of since the 2010 approximately. And we described together a cohort of 32 affected individuals and compared them to all individuals that were reported in the medical literature. So this was a review paper as well. And we published this in 2020 here. And Dr. Campeau and I, with Dr. Brandon Lee from Baylor, also wrote this gene review paper, which is kind of an online resource for a clinician to help with the clinical management of a genetic condition. And then, just to give you a little bit more background on myself, I also continue to do research training on the genetics of rare disease. I work with the Care for Canada Consortium in Ottawa in 2019-2020, and I'm currently doing a research fellowship at Boston Children, like I said, and I mostly work on new approaches to investigate on undiagnosed rare genetic diseases, such as novel gene discovery and identification of novel mutation. So now we're going to talk about, okay, so today I'll present an overview on KAT6B disorder. Here is the OMIM entry for the KAT6B gene, where you see that it's associated with two genetic conditions that we already talked a little bit about today. Genitopatellar syndrome, that I'll refer to as GPS, and Say-Barber-Bissiker-Young-Simpson syndrome, which we'll refer to as SBBYSS. So these two conditions were actually first clinically described without having a gene identified. Here you see that for SBBYSS, there's actually 5 authors who reported this new syndrome back in the 80s. That was characterized by the blepharophimosis, so the very small and underdeveloped eyelids, which leads to have like very small opening for the eyes, as well as ptosis. And a mask-like facial appearance, where you see that the face has less expression. And then GPS, on the other hand, was described about 20 years ago, approximately, and it was described in an individual who had small or absent kneecap, as well as flexion contractures of the lower limb. And then KAT6B was identified as the causative gene in 2011 by exome sequencing, which is sequencing of the coding part of the genome. And then back in 2011 and 2012, it was found that mutation in KAT6B are causing both GPS and SBBYSS. So you've seen this figure many times already today. Just a quick refresh that KAT6B functions in a complex with other proteins that include KAT6A, sorry. So you see that they have very similar function and they work together, but you'll see that clinically these two conditions can be also distinct and have their own features. And we have already discussed that KAT6B basically adds an acetyl group to histones, which lead to relaxation of chromatin, and this is how it's going to determine how DNA is packaged and how genes are read and how genes are accessed. And this process regulates the expressions of multiple downstream genes. Previous work has shown that KAT6B particularly acetylates histones H3 here in the histone protein. We also heard a nice talk this morning about epigenetic signature. Just a quick recap here, but this was covered that in 2018 a specific DNA methylation profile in blood samples from affected individuals was identified, and this can be tested in a clinical lab as of now. So now I'll just give you a brief overview of clinical features that are observed in individuals who have a KAT6B disorder. This is based on these two papers. So this 2020 paper here that reported more patients and was a review, and also this gene review here. So here you see some clinical photographs of some affected individual with KAT6B disorder. Here for SBB-YSS, you see the blepharophimosis. Maybe this is a little small for you guys at the back, but basically there's ptosis, so the drooping of the eyelids, the mask-like facies, the smaller eyelid. You also see here the long thumbs and the long great toes. And for GPS, you see some absent kneecap and some contractures of the knees and also of the ankles, causing club feet. So GPS and SBB-YSS have been historically described as distinct disorders with respect to their clinical findings, but they have several overlapping features, such as developmental delay, intellectual disability, heart malformation, feeding issue, and language delay are main concerns that many families are faced with. Hearing loss and thyroid anomalies can also be present in both, but some features are more present in one condition versus the other, such as the contractures of the knee or the hip are seen more in GPS. The agenesis of the corpus callosum as well, which is a midline structure in the brain that can be missing when doing a brain MRI. Renal anomalies are also more seen in GPS, with hydronephrosis and multicystic kidneys being the most commonly seen. And then the facial feature that we talked about before are more seen in SBB-YSS. But there are other anomalies that can be seen as well when we look at all the literature and all the patients put together. So some anomalies can be seen prenatally, so during the pregnancy. That includes malformation that would be severe enough to be visualized on an ultrasound, like renal, genital, or cardiac anomalies. But there's also other prenatal anomalies that have been described, like increased nuchal translucency or cystic hygroma, that is extra fluid in the neck that is seen on prenatal scan at about 13 weeks of gestation. Increased amniotic fluid also has been described. And other common neurological findings in KAT6B disorders can include microcephaly and visual impairment. And seizures can also be seen in a minority of individuals. Hearing loss also can be present in about 10 to 20% of individuals, so it's important to keep that in mind and to follow that as it can change with time as well, especially the conductive hearing loss. And then cleft lip and palate and high arch parted has been described, as well as dental anomalies like delayed eruption of teeth or absent or smaller teeth. Anomaly of the thyroid gland, such as a smaller or a thyroid gland that would be missing, has been described, or also abnormal function, so hypothyroidism. So that's also something that's important to follow in individuals with KAT6B disorder. And then to finish here, we talked about the GI issue, so the problem with motility and the feeding issue. That's a main concern. But there's also other things to look for, such as anal anomaly. For example, an anus that would be more anteriorly positioned. So that's an anus that's just a little higher, and that can also contribute to constipation. So that's something that a clinician should also evaluate. And anal atresia or anal stenosis, so that's when the anus is absent or just smaller. That's something that is on shortly after birth usually. That also has been reported. Individuals can have other skeletal anomalies than the one we described already. We talked about the kneecap and the contractures, but there can also be anomalies of other bones like the spine, the ribs, the hands and feet. Also, it can be a broad clinical presentation. And now I'm going to jump to discuss the type of genetic variation that are found in individuals with KAT6B disorder. So The variants that are more often seen are nonsense and frame shift variant. So here you see an example of a nonsense where the C here has been replaced by an A, and this leads to, this changes the genetic code and it leads to a stop codon, so it leads to a termination of transcription. Here an example of a frame shift where there's actually a gene that has been inserted or added in the sequence, and this leads to a frame shift, so a change in the genetic codes for multiple residues, and also leading to a premature stop codon, and then the termination of transcription. So this is a figure from the paper that we wrote with Philippe, which kind of almost has all the KAT6B mutation back in 2020. There's a couple that have been published now, so this figure would have more. But here you see a schematic of the gene with the reported variant. You see that most pathogenic variants are often located in the exon 18, which is the last, actually I'm not pointing, so the last exon here of the gene, which is exon 18. And you see that there is a codal code, and there is some genotype-phenotype correlation that can be made. So the blue here is GPS, and the orange is SBBYSS. So you see that variants that are more associated with GPS, they occur at the beginning of exon 18, right here. Whereas variants that would lead to SBBYSS, they occur kind of throughout the gene, or at the end of, if you see the orange here, at the end of exon 18, or earlier in the gene. And then you see in green, these are intermediate phenotypes, so it's individuals who have kind of features of both, and that clinicians are kind of not able to say oh, this individual has GPS or this individual has SBBYSS, and more of these individuals are being reported. And you see that it's even the same variant, so the same genetic mutation can be here, for example, associated with SBBYSS, but also an intermediate phenotype. And here the suspected mechanism that is thought to lead to disease is that probably that these variants that are at the beginning of exon 18 for GPS probably leads to a truncated protein. So the protein is not destroyed by the cell, it's produced as is, but it's just shorter. And so it's a protein that lacks the end part of that gene, so the C-terminal domain. And the hypothesis here is that there's some sort of gain of function or dominant negative effect that leads that the KAT6B is kind of trying to do the work, but it's disrupted and altered, and the binding with all the partners is not occurring as it should. Whereas the pathogenic variants that are actually causing SBBYSS are thought to result from a complete loss of function of the gene, meaning that if there's a stop earlier near the orange here, if there's a stop here, then this copy of the gene is just not produced, it's not present at all, and there's just the other copy that's present. And this is what would be leading to SBBYSS. And here, all the little stars means that that's a stop, just I should have said that earlier. And this is a recent paper that has been published in 2021, which present 29 new affected individuals with KAT6B and KAT6B disorders, and there's 10 novel KAT6B variants, and there are some additional clinical findings also that have been reported there. So the phenotypic spectrum keeps on expanding, so as we better understand the natural history of this condition. So other visual anomalies were reported, such as keratoconus, which is a specific anomaly of the eye, sensitivity to light or noise, recurrent infection, and more fractures than expected also compared to other kids. And then seizures were also reiterated as being a clinical finding, as well as hypothyroidism and polyhydramnios, which is more amniotic fluid during the pregnancy. Most of the time when familial testing is done, the KAT6B variant or mutation are de novo, meaning that they start with the affected individual and they are not inherited in the family. But there's, in the literature, there are 3 families that have been described as having a familial KAT6B disorder with multiple affected individuals over many generations. So here this is a mother and her child from the paper that I published where they both have a mild presentation. If I come back actually to this figure, in general, like obviously this is not always easy to predict, but in general, when the mutation is more proximal, so a bit more towards the beginning of the gene, in general we observe that these mutations here in these the more proximal exons lead to a milder phenotype. Obviously there are exceptions to that, and then the mutation that occur in this last exon leads to a more severe phenotype. So these mutations that were inherited from parents that were not significantly affected but still have some neurodevelopmental issues and some other milder features were also more proximal in the KAT6B gene. And in general, there are some things to follow when a kid has a diagnosis of KAT6B disorder. So there's some evaluations for congenital anomalies that should be done at the diagnosis or were done before the diagnosis, such as evaluation of genital and anal anomalies, the evaluation for limb contractures, echocardiogram, and renal ultrasound. These things are really like birth defects, so they would not appear over time, so it's not something that needs to be followed. But the ophthalmological evaluation can be repeated, as some kids, as you know, can evolve and develop some visual impairment, and same with the hearing. And it's also important, as we realize that there's approximately 10% of kids who have seizures, so it's also important to keep a clinical suspicion for that, and then do an EEG if needed, and also have a cerebral MRI, as I didn't mention it, but there are genesis of the corpus callosum, but other brain malformation can also be present. And as we discussed, there was also hypothyroidism, so that's also something that can happen over time. So that also should be kind of monitored by a clinical provider. So in conclusion, GPS, SBB-YSS, and the intermediate phenotype, they are all part of a broad phenotypic spectrum. And there are still some overlap in these conditions, but they also have some clinical differences. So I think it's still relevant to have these phenotypic differences. But here, like, there's still lots of research to do, and ongoing research is to understand the underlying molecular mechanism, and also understand better the clinical spectrum and the natural history. So there's one study that Philippe, my former supervisor, is still doing. If ever you are interested in participating, it's a neurodevelopmental study specifically for KAT6B. It involves a survey that is filled online, and we can chat about it more if you want. But it takes a lot of time to fill that survey, so you need to be patient. But Philippe is working with a psychologist, and they're collecting this data to better understand especially the language problem that hasn't been really addressed in previous papers. And one last thing I'd like to mention as well, which probably does not apply to most of you here because you already have a molecular diagnosis, but one of the projects I work on at the Broad Institute in Boston is the Rare Genomes project. It's a project that does genome sequencing for families who are undiagnosed and are suspected to have a rare genetic condition. So here in this case, maybe you know families who struggle to have a diagnosis, have had exome sequencing but don't have a conclusive result, or even don't have access to exome sequencing for insurance reasons, for example. So this is something I can talk to you more about if ever you know someone that could apply. And also KAT6B can be clinically diagnosed, and sometimes the mutation can be not have been found. So this is also something that could apply. Thank you very much. Here is my email, and I'm here until 7 p.m. Happy to meet any of you and continue discussions. Thank you.
Thanks, Dr. Lemire. Questions?
Great talk. So do the parents and the kids that, like the non-de novo cases, do they share similar phenotypes or same phenotype? Has there been enough research?
You mean like all of them together or within the
No,
same family?
like the mom and the son, for example, in this picture, like.
So for example, in this case, the poor one was a little bit more affected because she came to medical attention. Sorry, is it me? It's me. Okay, thank you. There can be variable expressivity within the same family. So even if it's the same mutation, yes, a family member can be more mildly affected and another more severely affected. So yes, I think this has been seen, and just in this particular family here, who were actually my patients, the little girl came to medical attention at 1 year of age because of global developmental delay, so she seems to have presented more severely than her mother. Yeah.
I have a question.
Yeah.
Do you see brain malformations in this condition that are actually actionable? Like, is there a higher preponderance of hydrocephalus or a specific, like cortical dysplasia or something like that that could treat the epilepsy, or?
No.
Okay.
It's like very non-specific findings,
so,
minor.
So a brain MRI is something that someone might have, but not necessarily something that they need once they already have the diagnosis.
Yes.
Okay.
I agree. Yeah.
Gotcha.
Any other questions for Dr. Lemire?
What was the name of that organization again, that does the genome sequencing? The Rare Genomes Project?
Yeah, I have a pamphlet, I can give it to you. Yeah.
Okay. Thank you very much, Dr. Lemire.